Good morning. We are transmitting live here from Amman, Jordan, from Farah Medical Center. And the backdrop is a slide showing the map of Jordan. We have the Dead Sea, and we also have the Red Sea. And the place to visit is Petra, Wadi Rum, and Aqaba. This is Aqaba. This is the backdrop of Aqaba, the city on the Red Sea, where you can do lots of water sports. And in addition, you can do snorkeling, diving. And this is King Abdullah of Jordan, diving in Jordan. That means that my daughter also is keen on this kind of sport, which I dare not do it. So we'll discuss the topic of today, the brainstem lesions, the clinical, radiological, operative, and pathological correlation. So we have to look at the anatomy of the brainstem. If we look from anterior view, you will see the brainstem, you will see the midbrain, the pons, and the medulla. Each is a continent on its own, and this anatomy is so complex, but so easy at the same time. And what kills me is to read a medical or radiological report saying brainstem is okay, as if you say Asia is okay. You can't say that. You have to be specific about the brainstem. Stop using the brainstem. You have to say midbrain, pons, and medulla, each on its own. Of course, all of the cranial nerves come from the anterior or lateral aspect of the brainstem, except one nerve, which comes from the back of the brainstem, which is the trochlear nerve. Other than that, all the cranial nerves, the 12 cranial nerves, come from the front. This is a close look at the frontal view. This is the hypothalamus. This is the mammillary bodies, anterior perforated substance. This is the crus of the brainstem. The crus is part of the brainstem, and it carries the pyramidal system. This is the corticospinal tract, and this is the corticopontine tract, and this is the cortico-parieto-occipital tract. And they are arranged as such. Why I'm saying this? Because this has a bearing on the surgery of the brainstem that we are going to see. So again, close look at the crus cerebri. That's carrying the pyramidal system, the motor system, the frontopontine, the corticospinal, and the parieto-occipital fibers. This knowledge is important. Again, here you can see the white matter dissection of that. So midbrain, pons, and medulla oblongata, and the cranial nerves coming out of it. If you open a window here, this is cadaveric specimen, then you'll go into the fourth ventricle and you'll see the choroid plexus. What if we look from behind, from posterior view, looking at the back of the brainstem? This is the pineal body, this is midbrain, and this is the part of the midbrain which is seen from the back. It's called the tictal plate, and it's made of superior colliculus, inferior colliculus, superior colliculus, inferior colliculus. Each has its own function. And then we'll have the pons, and this is the cerebellar hemispheres. Again, if you dig here, you will come to the fourth ventricle. The floor of the fourth ventricle is this shape, two triangles, top triangle and the lower triangle. The top triangle is related to the pons. The lower triangle is related to the open part of the medulla. Medulla is made of two parts, closed part and the open part. Open part because it opens into the fourth ventricle. And there is a line, which you can see here, it's called stria medullaris. That's the line that divides this into upper triangle and the lower triangle. And here is the facial colliculus. Again, this is the floor of the fourth ventricle, the two triangles, I mentioned the upper triangle and the lower triangle. Stria medullaris, that separates both. And here in this spot is the facial colliculus. And I'll come back to that. The weakness point of any doctor is the neurology. And the weakness point in any neurology is the brainstem. It looks so complex, but when you understand it, it's so easy. The thing is that just to dig deep into understanding it. When you look at this, you say, I don't want to hear about it. So complex. So let's make it easy. There are the nuclei of the cranial nerves, and here is these are motor ones, and these are the sensory ones. Again, it looks like complex, but it is not. If you know, start with one and then build it on, then you will, it will be easy. So I will do that with you step by step. This is the cut section of the floor of the fourth ventricle. And this is the median sulcus. This is the stria medullaris. This is pons. This is medulla. This is the open part of the medulla, the closed part of the medulla. And here we have the nucleus of the abducent nerve. And these are the fibers of the facial nerve going around the nucleus of the septic nerve. So what we say is a facial colliculus is not the facial nucleus. These are the fibers of the facial nerve going around the septic nerve nucleus. Nevertheless, if you go there, you will damage both. So let's look at the brainstem from the top. This is the tentorium, separating supratentorial part from the infratentorial part. This is the midbrain coming through the hiatus within the tent. There's somebody talking on the phone or somebody. Here we have removed one leaf of the tent, here the same. Both of them, we are looking at the superior surface of the cerebellum. Cerebellum has three surfaces. This is one of them. It's called tentorial surface because it is towards the tent. And then we have a surface here towards the petrous one called petrous surface. And we have surface related to the occipital bone, and this is the called occipital. Excuse me, anybody who wants to talk, please leave. I don't like people talking. Either I talk or you talk. Still talking. This is disrespect for the speaker. Sagittal cuts will show you the brainstem, the midbrain, the pons, and the medulla. So you cannot speak about brainstem. You have to speak about each and every one. Radiological report should speak about midbrain, pons, and medulla, each on its own. It's the easiest thing is to teach a resident in radiology about brain radiology. Ventricular systems are okay, brain parenchyma is okay, no aneurysm, no events. That's the report I hear and I read, and this is ridiculous. If one of these reports go abroad, they will say that we are retarded. Again, the tracts within the brainstem looks also very complex. Let's make it easy. Very complex, looks very complex, very busy. The easy thing is to think about it this way. The tracts, the longer tracts, they travel in the anterior part of the brainstem, whether midbrain or pons or medulla, while the nuclei of the cranial nerves, they lie to the back. So in the back of the brainstem here, you'll find cranial nerve nuclei, and the anterior part here, you'll find the long tracts. So the best way to reach the brainstem is lateral. You will avoid the long tracts, you will avoid the cranial nerve nuclei. Let's look at the transverse cuts. And here is the complexity. It's not complex. This is the crus, this is midbrain. This is the crus of the midbrain. Contains the corticospinal tract in the middle, the corticopontine, the corticopontine part, and the parieto-occipital part. This is substantia nigra. This is radionucleus. This is medial lemniscus of the sensation, and this is the spinothalamic of the pain. This is Edinger-Westphal nucleus of the third nerve, medial and fasciculus, central tegmental tract. It's the same replica. The third nerve comes from its nucleus and goes to the front, while the trochlear comes this way and goes from the back. Why am I saying this? Because we're talking about brainstem surgery. So where is the lesion depends and shows the anatomy. How do I deal with this one, which is coming from posterior, or this one coming lateral, or this one coming from anterior? So I have to have the knowledge of these tracts to be able to do brainstem surgery. This is a cut section of the pons. Again, seems to be complex. Again, it is not. Anterior part are the pyramidal tracts, the long tracts, and behind is the cranial nerve nuclei. Same thing. The lesion will decide which way to go by anatomy decision. Again, here I refer back to the so-called facial colliculus. We are looking at the floor of the fourth ventricle. This is the nucleus of the sixth nerve. This is the nucleus of the seventh nerve. Why? Seventh nerve goes this way, and comes this way. Why should it come this way? The explanation for this, it's called chemotactic theory, which I don't want to dwell about, but it's a very mysterious kind of theory. But this is the facial nerve fibers going like this. If you go into the facial colliculus, which is the facial fibers going around the sixth nerve nucleus, you will damage sixth nerve and seventh nerve. A section of the medulla, the closed part and the open part. This is the open part. Again, still the pyramidal system is in the front, and the cranial nerves are in the back. Again, where the lesion and the pons or the medulla defines which way to go. So we know some about brainstem anatomy. Let's see what happens to the brainstem in terms of pathology. What are the brainstem lesions that we see? One of the commonest things that you see are the gliomas, and this is called thalamo-mesencephalic. Mesencephalic means midbrain, between the thalamus and the midbrain. Thalamo-mesencephalic. This is midbrain, also going into the thalamus. This is tictal plate of the midbrain. This is tegmental part of the midbrain. This is the brachiopontis of the midbrain. And this is the open part of the medulla. This is the closed part of it. And this is the spinal cord. So this is midbrain glioma, and it is around the aqueduct, and it's called periaqueductal glioma. A better name for it is called pencil glioma. This is again glioma in the upper part of the midbrain. This is a girl whom we operate upon. This is the histology, pilocytic astrocytoma, very benign lesion. Again, this is the lesion in the back of the midbrain. And again, it was an astrocytoma in this girl, which we operate upon. And this is the post-op, and the histology, and the follow-up. This is collection of the pontine gliomas. And whenever you see an arrow or an asterisk, this is not my collection. This is from Anne collection. And this is kind of the gliomas that you see. Diffuse, localized, etc. A case of mine, 15-year-old. Mind you, brainstem gliomas are usually a disease of children. And this is kind of a glioma in the pons. It's here involving the pons and the medulla, and it's going out. And we call this exophytic because it is coming out, exophytic. This is, most of them are benign, most of them, but some of them are malignant. The point is that benign or malignant, the anatomy is malignant. So this is a glioblastoma of the medulla oblongata. Again, this is the exophytic type, so it's coming from the medulla out. This is preferred from the other types, which is called intrinsic. is inside the brainstem. This, if you go this way, you can reach it. While if it is inside, then you have to go through normal brain tissue, no brainstem tissue. So this is called exophytic type of glioma. And this is called focal type of glioma. This is called diffuse type of glioma. So gliomas are either focal or diffuse or exophytic. Another lesion which is common is cavernomas. And again, this is a patient of mine, 8-year-old male patient with this midbrain tictal plate. This is tictal plate. This is tegmentum of the midbrain. Again, a radiology report should say this. You just cannot say brainstem is normal. Tell me, midbrain in its 2 parts is normal, pons is normal in its 2 parts, medulla closed part and the open part is normal. And tell me why this lesion is a glioma. Because in T1 it shows this, in T2 it shows this. So a report should be elaborate and not 3 lines. So this is a cavernoma. This is tegmentum, not tictal plate. This is tictal plate. This is tegmentum of the midbrain. And again, you can see the lesion. It can be small, it can be large. Pontum is encephalic. It's in the midbrain and in the pons. Pontum is encephalic. And this is totally pontine glioma or cavernoma, sorry. And this is a collection of pediatric cavernomas. Cavernomas can hit little children, and usually they come with a bleed and cranial nerve pulses. Cavernoma of the pons. This is called exophytic. This is good. This is bad. This is intrinsic. To reach it, you have to go through normal tissue. Here, extrinsic. If you go to the fourth ventricle, it's good. And this is medulla cavernoma. It is within the medulla. So various types of medullary cavernomas. Hemangioblastomas are common, again, a common lesion in the posterior fossa and the brainstem. And this is my series of hemangioblastomas. Some of them, actually, not all of them, have a big series of these hemangioblastomas. They can occur, of course, supratentorial or infratentorial. Commonly in the infratentorial, they come in the cerebellum, but also they can come in the brainstem. The notion that hemangioblastoma is a cystic lesion with a nodule is no more. Hemangioblastoma could be totally solid without any cyst. And they could be just sitting on the surface of the brainstem or embedding itself, or it could be totally intrinsic. This is totally solid, no cyst in it. And these are the most difficult. Why? Because they have feeders and they have drainage. They are just like AVM. They are notorious more than AVMs. So you can see, if you do angiogram, you will see the plush, you will see the feeders, you will see the drain veins. It could be a solo lesion, or it could be part of bone Hippel-Lindau disease, where they have multiple hemangioblastomas in the brain and in the spinal cord. Tumors can come to the brainstem from surrounding structures, and we discussed this last time, coming from pineal gland or anything else like germinomas or non-germinomas. We discussed this last time. At the end of the day, you will be operating on the brainstem. Epidermoid going into the midbrain, or a meningioma going into the whole of the brainstem, or a lipoma like this. Again, we discussed this last time in the pineal lesions. This is the operative photo where you can see the lipoma sitting at the back of the midbrain, and this is the fourth nerve. Other diseases that affect the brainstem, you can get infarct. And then you will wonder, is this an infarct or is this a tumor? Again, whenever you see an arrow, this is not my collection. This is from Anne's book. And this is a picture also of the brainstem infarct due to basilar artery involvement. You can see it's affecting both cerebellum and the brainstem. A hypertensive bleed can present in the brainstem, and we think it's a tumor. Vasculitis. Again, we forgot about these pathologies because we think in one track. What's just one track? Abdominal pain, appendicitis, ovarian cyst. We forgot about all pathology. Sinuses, tonsils, and that's it. We stop thinking at that level. These diseases exist. There are patients with Behçet disease and lobus coming with vasculitis. Vasculitis is an ocean of diseases. Don't fall, please. Encephalitis. Again, our neurologists in the audience would appreciate these pictures. Encephalitis. There is an entity called brainstem encephalitis that comes just in the brainstem, and it needs a special EEG to show it. Deep electrode EEG. Acute disseminated encephalomyelopathy, ADM, acute disseminated encephalomyelopathy, affecting the brainstem and the spinal cord. Encephalitis due to HIV. Do you see this often, Allah?
No, not often.
Not often.
When you say of HIV, you say
It's done. So it can also present like this. Wernicke encephalopathy, Korsakoff syndrome, Dr. Amun, I've seen you in the audience. Do you see any of these cases?
Yeah, no.
No, but in the States you do. Why is that? That's because of alcohol. Yes, thank you. People here drink too, but not as much as. Osmotic demyelination syndrome. This is very important in pediatric group. Aneurysm. Aneurysm, is this aneurysm? Yes. This is a viable, alive aneurysm. This is a thrombosed aneurysm. It looks like a tumor. So people, like in the insurance companies, they don't want you to do angiogram. Why should you do angiogram? Why should you do CBC? You just get the patient the same day. Why should you admit him before? MS. MS is famous. 7 to 9 lesions periventricular in the spinal cord and in the brainstem. Female, young. Brain abscess, infection. Tuberculosis, tuberculitis of the brainstem. Again, we forgot about these diseases. We practice with one wheel. Sarcoidosis. So pathology of the brainstem is massive. What about the images?
May I comment?
Yeah, of course.
Morning and Happy New Year. This is really important. These are actual cases that you've seen. These are not hypothetical brain exercise. And I cannot emphasize the importance of this further. Sarcoid can happen on the brainstem, and this can be masked by giving this patient steroids and just wait upon them. And I've seen this happen. This is a very rare occurrence, but it can happen. And when you give patients steroids with a presentation like this, and they have tuberculoma, you're going to kill these patients. The same would apply to brain abscesses. MS lesions that happen in the brainstem without anything else also would be masked by steroids. These patients often would be mismanaged by giving them steroids. The lesion would improve, and things would be buried beneath the carpet, and then they will come back with a vengeance and die. I can't really emphasize this enough. And when you see enough of HIV, you're going to definitely see this. But unfortunately, this is rare here, though it is underreported. I want just to mention a few other things that will have severe implications upon the management here. Can meningiomas happen in the brainstem, as Dr. Brahim? Definitely they can. Germinoma, that's really important, because if you miss that diagnosis and you bury the diagnosis with radiotherapy, because you label them as brainstem lesions that are non-biopsiable, you are missing a potentially curable malignancy. The primary CNS germ cell tumors can happen in the brainstem, and they're cured with platinum-based regimens to be followed by conservation radiotherapy. Hemangioblastomas can happen here as well. And I want to mention a few other lesions that will have a definite implication on management. Now, the presumption in most of these cases that these are brainstem gliomas, and they are managed as such with radiotherapy alone. Now, granted, a lot of these patients will have brainstem gliomas, which is one of the most common diagnoses in this region. Now, the reason why we emphasize these points, I'm sorry.
Why do you always refer to the fact that is steroids a standard treatment? You always say
They're not standard treatment, unfortunately.
Yeah.
Unfortunately, I cannot tell you how frequent this malpractice is. You'll get a patient with brainstem lesion. Somebody will tell them, oh, this is in the brainstem. We cannot get tissue diagnosis. Give them steroids, give them radiotherapy, send away. I cannot tell you how many times we have this, and in meetings, I continue to bang on the table, for God's sake, I need tissue diagnosis. Now, granted, there are cases that the tissue diagnosis is going to be very difficult to get, but there's a difference between an expert neurosurgeon like Professor Subeh telling me that I can't get you anything, and a mediocre surgeon telling me I can't get you anything, and just give steroids and simple radiotherapy. These are the examples I continue to hammer, unfortunately, happen every single day.
Not only that steroids are given to brain lesions, they are given to disc prolapse. I have seen doctors and neurologists and other people giving just the steroid for a disc prolapse and just waiting him until they develop foot to drop and then they refer him. There is a lot of malpractice in the third world, a lot of mediocre internists and mediocre radiologists and mediocre neurosurgeons. We have to face this if we want to get along and progress further. We have to admit that we have a malpractice which is very infectious in this kind of part of the world. I'll just proceed with that.
At CPM, I see a lot of CPM.
Yes.
That give steroids.
Yes, of course. Lots.
CPM.
Yes. Lots. Because he's a mediocre and he doesn't know what to do, so they give steroids. Again, to stress that brainstem, because Dr. Jarir just stepped in, brainstem is a territory whereby a lot of pediatric population gets involved. So back to the images, CT scan could show you hemorrhage, it could show you the lesion itself, and here in this specific CT, you'll see something peculiar that very few people think about, so-called developmental venous anomaly. It's very important, I'll come to it. MRI, of course, T2 is very good to show cavernomas, for example. The gradient echo is very important to show the hemorrhage, and we have 4 types of the cavernomas: Zebra-Mesky type 1, Zebra-Mesky type 2, 3, and 4. Again, this is an area where very few people know, where very few people would ask. I would love to put such a picture for a resident who is sitting for the exam, and I tell you, no one would answer it, though they should know it. But their teachers don't teach it because they don't know it. The anatomy of the venous system, as if it does not exist. Venous system is nothing. It's the arteries are important. Venous system is very important in every part of the body, especially in the brain. We have to know these veins.
And you be blamed for what's
They would say the skull-based surgeon asking us, it happened. They complain against me asking about the carotid artery. So here you can see the vein of Rosenthal, starting of the central veins, in terms of the cerebral veins and so on. A new development in MRI, now our radiologist would agree, is the diffusion tensor imaging or fractography, where you can see the lung tracts. You'll see the medial lemniscus, you'll see the corticospinal tract, the medial lemniscus in 3D. That would help you to start what kind of approach would I do, and what is the relation of these important tracts in the management. If you affect the corticospinal, it's hemiplegia. If If you affect the medial meniscus or the spinal thalamic, then it is hemianesthesia and so on. So you can see these tracts on the tractography, the long tract and the inferior cerebellar peduncle. As I said, not only you see the tracts, but you see a relationship with the lesion. And each color code means something. Well, I'm not going to dwell on that. But once you know it, it's easy. Look at this example, which is a right frontal oblique view. The purple is the corticospinal tract, and the pink is the medial meniscus of the sensory tract. You can see the relationship with the lesion.
This is an MRI.
This is, yes, that is,
What
yes,
is the type of this radiological examination?
tractography. Yes.
How can we do it? Fusion.
We have, yes. Yes,
How recent is this technique? For how long have we been using it?
it's been for years.
10 years.
10 years?
Yeah. We have it, hasn't
I think some machines they have the capability to do it, but they are not 10 years old.
Do you have it في المدينة كنتم مثلا؟ Yes.
How do you select
10 years old.
each tract? How can you select this tract?
There's a technique that you can show the motor tracts and the sensory tracts. Look at this here again. And this, for example. It's beautiful. Look at this. Here you can see the lesion, you can see the spinal thalamic, and you can see that this is affected. Medial meniscus is infiltrated on this side, while on this side it's okay. I'll show you this quick video. Now we'll go into the surgery of the brainstem, and this is an introductory kind of video.
Approaches to the brainstem make use of the various secondary zones, which are areas of brainstem that can be traversed with relative ease, but thus corresponding to normal brainstem function. These areas are depicted in colored lines and shapes of midbrain, pons, and the medulla on the ventral, lateral, and dorsal surface. There are a variety of critical entry zones for each region, including early midbrain, midline, paracollar, and lateral zones. And perioptimal motor stimulation. At the level of the pons, there are supratracheal, middle, cerebellar, and peritracheal lines. At the level of the medulla, we can see voluntary entry zones and lateral and dorsal entry zones into the medulla. The dorsal entry zones are depicted here. These zones are voice vertical structures which otherwise these entry zones are often used for lesions that are not close to the fetal orbital surface. In cases where a lesion above the fetal orbital surface is usually best approached directly by scanning the area where it comes to the surface most closely. Careful study of these entry zones will provide surgeons with optimal approaches to those areas of brainstem. The selling of these lesions in terms of this surgeon will be going to offer patients treatment.
This was a film that was made by Professor Spitzler from Barron Neuroscience Institute. Spitzler visited Jordan many times, and he's a Jordan friend. So we'll elaborate on what we have seen to put it into practice. Let's have a look. Surgical approaches to the brainstem are many. I will explain each and every one of these cases, but there is a sort of theory about it. This lesion is in the midbrain. This is the cus cerebri. which means that we are dealing with the pyramidal tract, corticospinal, corticopontine, corticoparietal. And this is the lesion just there in the crus cerebri. Which way to approach it? It's called 2 points. The deepest point, the most superficial point, and then you pass it and you say, well, this is the best approach. But here in the pons, for example, this is the point and this is where it comes to the surface. If you come this way, you will damage the pyramidal tract. So you will come this way. So there is a sort of modification that you want to do to decide which approach you want to do. Let's see the anterior approaches, and one of these is the fronto-orbitozygomatic. Fronto-orbitozygomatic, to that you can reach to the crus cerebri. You can go this way, and you can go to the crus cerebri, like the region we have seen. Here, you know that you can go between this and this. This is the corticoparietal, this is corticospinal, so you can go through this. This is one non-approach for that. So you want to go here, in this area. Frontoparietal to the corticospinal, you can go in here. Or you can go in other places. But this is anterior view. So again, this is the crus cerebri. This is the lesion that I described. It's in the crus cerebri. But if you go this way, between here and here, then you are safe. You cannot do this unless you know the anatomy. So this is the anterior mesencephalic zone to go this way.
This MRI is your best mapping
Absolutely.
system.
And if you have tractography, that would be good. With your anatomical knowledge, that adds. With your surgical experience, that adds on. So brainstem is not a place for the beginners or the novices or the mediocres. So here you can go through the fronto-orbitozygomatic. You can come to the side of the brainstem here. This is the carotid, anterior cerebral, middle cerebral, and so on. So you can see, like you go for basilar aneurysm. And this is kind of lesions that you deal with this, kind of approach. It's anterior here. So you study that, and then you do. Again, a fronto-orbital because you're anterior lesion. You go between the superior cerebellar and posterior cerebral arteries, where the third nerve comes off the front of the brainstem. Also, for one of the anterior approaches is to go through the ventricles. So this lesion is in the midbrain, and if you approach this through the ventricle by going into between the two internal cerebral veins, like this, you can remove it. Sometimes you'll use endoscopy, and endoscopy is the future of neurosurgery. I advise my residents to go and have endoscopy training. It is the future of surgery. Here is the transoral, because this is completely anterior in the pons. Either you do prepontine, which is complex, or you go directly transoral, and that's the view you'll see. You'll see the basilar arch in front of you. You will go and remove the lesion. Not easy, but possible. Another view is to go lateral to the brainstem, not here, the anterior, you go lateral. It's called lateral mesencephalic sulcus. There is a sulcus here. And there's a vein here. It's called lateral mesencephalic vein. And then you can go through that safely. Again, just remind you of the anatomy. If you know this cut, you know that you can go in here. You know that you can go in here. You know that you can go in here. So this is the vein of the lateral mesencephalic sulcus, and you go in here. It says you are behind the crus, so totally, completely behind the crus, between substantia nigra, which is this, and the medial lemniscus. So you can go and do it safely. And this is what we are saying, the lateral mesencephalic sulcus. Lateral. Also lateral to the pons is that if this is the trigeminal nerve, you can go above it, supra-trigeminal, or peri in front of it, or underneath it, between the trigeminal and the facial, laterally. So again, this is safe area to go through. There it is, between the trigeminal and the facial, trigeminal and facial, above it, anterior to it. There it is, trigeminal, facial. So this area, the lateral area of the brainstem and the medulla. Again, here is the cavernoma, and you know your anatomy. You will avoid the corticospinal tract, which is anterior. You will avoid the cranial nerve nuclei, which is posterior. You'll go between the trigeminal nerve and the facial nerve safely. And this is the cut section where you can go. So you can go this way, as I said, laterally. It's again anatomy knowledge. How many of medical students in the world knows this? No. How many of the neurosurgical neurological residents know this? Very, very few. And how many of the practicing surgeons? Very, 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 very few.
Hence, most of the lesions in the actual world in these locations are termed inaccessible.
Absolutely, and this is glioma sent for radiotherapy without any. This is the medulla oblongata. Again, here's the anterior view, pyramid and olive. You can go so-called anterior lateral sulcus, like this. So one of the lesions that like this, that you want to approach. We can use the retrosigmoid approach. So you take the brainstem this way, and then you go into the brainstem and find it. But this is rather easy if you understand what I'm saying. It's not easy, but because it is presenting to the surface, so you'll see it. The difficult ones are the ones that are located inside, the so-called intrinsic ones. This one is massive, affecting most of the midbrain. So what should you do? You do pre-sigmoid approach. Pre-sigmoid means in front of the sigmoid. We all know the retrosigmoid behind, but the pre-sigmoid is a skull-based approach that very few can master. You can go through a small triangle here. This is on the left side. You are taking the ear this way, and this is the mastoid here being drilled. This is sigmoid, so you go pre-sigmoid. And this is the way to do it on the left side. This is the anatomy, this is middle fossa, this is posterior fossa. You go through this. It's a very important approach, but it needs a lot of cadaveric courses and then practicing. And this is what it is. You just cannot go this way. It's difficult because the region is here. You can't go this way and this way. So what you do is to remove this and then go this way. That's the idea. Pre-sigmoid approach. It is not on the surface. It is intrinsic. It's more difficult. But to do this approach, you would actually go exactly where the lesion is. Subtemporal approach. Left side. Open the dura, retract the temporal lobe, and you come to the brainstem. Upper brainstem. You may cut the tent and then you go to the pons. So you can reach to places to do that. And this is one case of subtemporal transtentorial lesion. And this is transpetrosal Kawasate approach for a pontine lesion like this one. Or you can go, this is the transverse sinus, or the superior sinus coming this way, transverse sinus. And this is the occipital sinus, for example. And then you can go on the midline, or median, or you go lateral to it, paramedian, or go far lateral or extreme lateral. And this gives you different views of the back and the lateral side of the brainstem. This is what you see in the median, the paramedian, and the extreme. So if you are interested in this part, you'll go extreme lateral. Interested in this part, you'll go median. Median, paramedian, far lateral, or extreme lateral. That's above or below the tent. Median, that's it. That's the picture. You'll see superior colliculus, inferior colliculus. So you're directly on the back of the midline. We have shown you this previously in our film of the pineal tumors. So you open this, you go above the cerebellum, you'll come to this, what we call the shark view. And then, like in this case of mine, we are taking the cerebellum down, we are underneath the tent, we are at the back of the midbrain, and we are taking this lipoma out. Or far lateral, you just tell the patient, and then you'll see side view of the superior colliculus. And this is an example. It is not in the midline, it's a bit off. So you use this approach. Or extreme lateral or far lateral, where the lesion is really far like this. It is not in the midline, it is not lateral, it is far lateral. In this particular case of thalamomesencephalic, you go supratentorial, you cut the tent and you reach to the back of the midbrain and the thalamus. So posterior interviews or posterior approaches, as we said, here's the midbrain, you can go between the two superior colliculi or underneath the inferior colliculi, you are in the midline. This is the lateral mesencephalic which we described. Here is the medial sulcus. Medial sulcus here is okay, but here it's not okay, you should not open here. And you look for the facial colliculus. Again, here the midline is okay, and then the anterior lateral and posterior lateral views. This is the hypoglossal triangle and vagal triangle. So, posterior view or the midbrain, lateral approach, and as I said, the anterior approach. So this is the midline, median sulcus. Try to avoid it in most of the times, especially in here. This is the sulcus, and this is the so-called facial colliculus, which, as we said, is not facial nucleus. These are fibers of the facial nerve coursing around the sixth nerve nucleus. You go in, you damage both nerves. So you will choose an area above it, or below it, or lateral to it. So this is the median sulcus, and this is the facial colliculus. You go above it, or below it, or you go lateral to it. So here's the posterior approaches for the medulla. So occipital approaches, central midline occipital, and you come to the floor of the fourth ventricle. Or you can go and look into the aqueduct. So you can actually reach lesions in the midbrain, whether in the tictal plate or in the tegmentum. It's called tillo-velar approach. This is occipital. This is easy because it's presenting to the surface. You see the discoloration, you open over it, and it's finished. Tillo-velar, you want to go through the aqueduct. You can go retrosigmoid, transverse sinus, sigmoid sinus, you track the cerebellum, you get into this angle here, and then you come, so you come this way, and then you go this way. So-called far lateral approach, which is rarely used. It's very laborious. And we come now to the case of presentation today, which I will run through. My first introduction to cavernomas was this. 1986, I was still resident registrar in England at Kingston Hospital, St. George's University in London. And my boss asked me to present these cases. This is my boss then, Sean O'Leary. And we called it surgical treatment of cryptic AVMs. Why cryptic AVMs? Because we did not know they are called cavernomas. Cavernoma is a new terminology. Cryptic, بالإنجليزي يعني المخفي. في الجاسوسية you send letters by cryptic language مخفية. فcryptic معناها AVM بس مخفية. We don't see it on angiogram. And we presented these cases of the brainstem cavernomas and also spinal cavernomas. That was my first introduction to these cases. That was not my first paper in '86, that was my 6th paper as a resident. So, let's have a quick look. What is this cavernoma? Vascular malformations are two types. One with arteriovenous shunting, like AVM. There's a shunt of blood from arteries to veins. And ones without arteriovenous shunting. And we are dealing with these three types: cavernomas, capillary telangiectasia, developmental venous anomalies. Cavernoma is just like blackberry. It has feeders and everything, but we don't see it on angiogram. Capillary telangiectasia, like this one, is this type. And this, very important, DVA, developmental venous anomaly. This is developmental venous anomaly and supratentorial, and it's taking its feeders and drainage. This is the septal vein, thalamocyte veins, and this is the developmental venous anomaly. And it's called Caput Medusa. Caput Medusa is in the Greek mythology is this goddess with so many arms and legs like this. So this is Caput Medusa. You also see it. I've seen it as a medical student in Egypt with hepatosplenomegaly to tuberculosis. You will see Caput Medusa of veins on the abdomen. Yes, absolutely. And we should know whether it's draining up or down by putting your hands on both the draining areas, remove one and see whether it fills again and so on. And this is one patient of mine who came from Bahrain, 11-year-old. Again, remember, cavernoma is a disease of childhood. And look at him with sixth nerve palsy. He's looking straight. This eye is looking straight, but this eye is deviated medially. Sixth nerve is affected with this cavernoma. And DVA. It is said that there is not a single cavernoma without an associated DVA, and I agree with that. I have not seen a case of cavernoma without an associated DVA, developmental venous anomaly. What is the importance of this? It makes hell of difference. If you touch this, it will end in death. The developmental venous anomalies are abnormal, so they are drained, things in a strange way. Damage it, it ends on death on table or later on. So it will decide your surgical approach and everything. And it's also associated with telangiectasia. Again, telangiectasia is a part of the syndrome. So our patient for today, 23-year-old from Iraq, he presented with increased intracranial pressure, and this was coupled with cranial nerve deficits. He had ptosis, tinnitus, ataxic gait, and limb weakness. General examination was normal. That's him with left oculomotor, left trochlear, left abducent, left facial. All the cranial nerves on the left side are affected. So you can tell and you can swear that he has a pontine lesion, because this is the only way you can get these lesions. The brainstem must be pontine. Again here, the eye movements. He had also trigeminal affected. Decreased pinprick and corneal reflex are absent. And he had some mild facial weakness. And as we said, when you speak about facial weakness, you have to define the grade by House-Brackman. House-Brackman grading. He had cerebellar signs also. Finger nose test was abnormal. Left diazodekinesia, rhomboembolism, and slurred speech. He had also pyramidal weakness. So you can see difference. And some alteration, but not important in CBC and so on. Images, very, very saddening for me, very saddening. I say, how can I help this patient? It is not reaching to the surface, here or there. It's intrinsic. This is the most difficult ones. So I would hope that the patient would leave me and go somewhere else. He wouldn't. Him coming from Iraq for you personally. So it's not presenting here, not there. It's a big one. And not only big one, it's also going into the brainstem, midbrain, sorry. So here you are. These are the MRI images. You can see the lesion and the sagittal. Consultations we did, Dr. Mohammed Juma is not around. This patient was a little bit diabetic. And he advised that once we give steroids, then there would be the need for insulin coverage. We asked the ophthalmologist, Dr. Salam Takouri, who's not with us today, and he reported mainly nothing in his eyes. And we asked Dr. Hazem. Hazem is around. You did for us this angiogram. Why do we do angiogram, Hazem, for these cases?
Well, it depends. It depends almost on the location. I mean, when it's intracranial location, you do angiogram mainly to define the presence of DVA. And then next is capillary telangiectasis. The difference between DVA and capillary telangiectasis is that capillary telangiectasis, they have arterial blush, which is different, but they don't have arteriovenous something, which is a different entity. So capillary telangiectasia, you can see them by angiogram. for the infratentorial. For the supratentorial cavernomas, there is about 5% misdiagnosis of partially composed AVM that they present like a cavernoma, and then you do cerebral angiogram. Besides to define the DVE, but DVEs are more crucial and more important in the infratentorial because of the easiness of venous infarction if you occlude them or if you would go through them during surgery. So this is the main difference, and this is why still, despite this is a topic in INR for the need of still of angiography, but most of the centers, the consensus is you have to do angiography for these patients.
So if you have a DVA, this must have been a birth.
No, it's not. And that's what the insurance companies look for. Cavernoma is a congenital disease. The answer is no. But you are sentenced since birth to have them. It's different.
So you're
You don't have them at birth, but sometime in your life you will have them.
So you're predisposed.
Absolutely. And I always put what the consultant has written so that if he changes his mind, we will face him with that. This is the angiogram. As we said, 6 visual angiogram. Once you do angiogram, we do it fully. This is a posterior fossa region. Why should I bother about carotids? You are doing angiogram, so do it fully. 2 externals, 2 internals, 2 vertebrates. Not 1, 2. Anesthesia at that time was Dr. Jamal Sharif, and he announced patient fit for general anesthesia. I would take the opportunity today to ask Dr. Maawi Ababna, ask him kindly to tell us what are the intricacies of anesthesia for brainstem. Dr. Maawi?
Thank you very much, man. صباح الخير كل عام وانتم بخير. Thank you. Thanks for trying to make a very complex issue easy. Still, it's more complex for me now. I thought it was easier before your lecture. We are talking about brainstem, which is probably motherboard or black box of human being. Or then, as you know, brainstem death test. If we declare brainstem dead, that means human being is dead. And I thought at one stage, me and Dr. Ibrahim, we will talk about brainstem death testing, and because it's another issue, it's important. So it's a very complex issue, as he said. From an aesthetic point of view, probably most challenging anesthesia probably we faced during our list. We've done with Dr. Ibrahim since a long time, long time in many cases. And there are a few points to remember. Posterior fossa or infratentorial fossas, compact, rigid compartment with very poor compliance, which is different from the brain. And it got all beside cranial nerves, all where he didn't mention, all our vital signs centers, cardiac, respiratory, all these centers inside the brainstem infratentorial. And it is compact and has a very poor compliance comparing with the brain tissue. And any small additional volume, trauma, hematoma, or even oedema, for that matter, sometimes because of extraction, it causes a huge repercussion in the patient's parameters. And surgery, it has and anesthesia significant challenges. It can be done in prone position. It can be done in the sitting position, lateral position, park bench position. And usually, most of the time, Dr. does it in sitting position. Some other neurosurgeons, they do it in the prone position. There are advantages, disadvantages for each position, which I'm not going to mention because of the time in here, but we do it in this sort of sitting position. This is the sort of the patient during surgery with the legs probably at the level of the feet, at the level of the head, and the patient in this situation. Sitting position offers much better surgical access because it drains for the venous drainage, for CSF drainage, so the surgical field will be quite clear and visible for him, and there is no congestion. But on the other hand, if because of the venous pooling of the patient, especially if there is autonomic dysfunction in the diabetic patient, it offers quite a challenge to keep the blood pressure there in the brain in the mean of anywhere between 60 and 80 milliliters of mercury blood pressure. And when we measure blood pressure in here all the time, we will put the transducer to the level of the earlobe, not to the level of the heart, because the difference between the heart and if the mean blood pressure at the level of the heart is 60, there will be probably 40 or less, and you will end up in ischemia of the brainstem. So we have to measure the blood pressure there where he works. Patients on the sitting position must be returned to supine position rapidly for resuscitation measures. And I want to mention rapidly. How you can put this rapidly in supine, I don't know. But you have once or twice, yeah, exactly. I mean, you could imagine how many retractors in his brain or his skull. But we have to put, unfortunately, once or twice in our lifetime back when we have problem with the patient in this position. Complication of sitting position, just a few points. The cardiovascular venous pooling, as I said, in the legs, can result in significant hypertension, particularly in elderly patients or diabetic patients. Surgical stimulation can result, and this is we'll see it most of the time, hypertension, bradycardia, because as I said, brainstem is the black box of the human being, and manipulation or traction in this, we can see all these complications. Sometimes ECG changes or blood pressure changes during surgery may indicate that the surgeon is touching one of these centers, and we can tell him, please, either to stop or take the retractor sometimes before we will end up with catastrophe and disaster of these. Venous air embolism, this is the most common complication. We see it almost in every single case we see it because of, as I said, because of the sitting position, potentially life-threatening complication associated with surgery in the steep head-up position, and we see it there. It is incidence anywhere between 25 to 75%. It's large variation. Why? Because to see it clinically, you need more than 0.25 ml of air per kilo body weight to see it clinical manifestation. So probably some books mention probably 100% incidence of air embolism, but they are clinically not significant because they are minute amount of air. But it does happens in each one. Clinical feature, it depends, as I said, on the rate and the volume, not just the volume. Sorry? To see clinical manifestation, you need 0.25 ml per kilo body weight to see clinical manifestation. But if it is less than that, you won't see any clinical manifestation. Pneumococcus air causing mass effect in elevated ICP. As I said, this is least compressible compartment of the brain. Using of nitrous oxide could be a problem in anesthesia because nitrous oxide diffuses to cavities and make the pneumococcus even bigger and bigger. And sometimes we see it in delayed recovery, neurological deficit, headache, confusion, agitation, and convulsion. Best thing to do it, and we have it with Dr. Brian several times, to do immediate CT and bring him back to theater and evacuate it to have better problem. Macroglossia, I remember, if you remember a lady, we had one case. This is catastrophic. We have done with Dr. Brahim one case, and she ended up with macroglossia, and she was a young lady, and she stays like this probably for 6 or 7 days. And you could imagine if it does happen, it is catastrophic. It is, and only in children it might impair respiratory, and you have to ventilate patients. In adults, it might go without ventilation. But the problem, I mean, for the family, it's very traumatic for the lady or even for the family to see the patient. And we have, in the span of 30 years, we had it one time. And this is probably due to obstruction and because of the flexion of the neck, there was no proper drainage of lymphatic or veins. But when it happens, I hate it, and I've seen it once in my lifetime. It may cause possible respiratory obstruction, as I said, particularly in children. Quadriplegia, touch wood, we never saw it. It's a rare complication, potentially disastrous because of position. We have to mind it. Meticulous attention to the position. By the way, to anesthetize and put the patient ready for him in this position probably needs hour and a half. If you want to make safe surgery afterwards, safe recovery, and for the patient to go home or to intensive care rightly, you need hour and a half to put this patient in this position anesthetized. Pre-op evaluation, as any patient should be investigated, probably with the stress in PFOs, because if there is any communication between right and left heart should be detected because of incidence of paradoxical air embolism. As I said, clinical manifestation of air embolism is 0.25 ml per kilogram. Unfortunately, paradoxical air embolism can happen even with 1 ml of air and with catastrophic disaster. Incidence is quite high. Any communication between 10 and 35%. So I would suggest to do an echocardiogram for all patients going in sitting position, just to exclude there is any communication between right and left heart. Because if there is a communication and you've got a very small air coming in the system, you might end up with a disaster, stroke in the brain, and catastrophe, an outcome of the patient, and you won't have it. Monitoring plus routine monitoring. We need an invasive arterial line. We need central line for both to monitor the patient intake, and if there is an air embolism, and you've seen we've used it several times with Dr. Maheen, you can withdraw some air from the air embolism, especially if the volume is high. You can use it to throw some air. Anesthetic technique, there is no difference between any anesthetic technique you are comfortable with, just to avoid significant increase in intracranial pressure, to maintain cerebral perfusion pressure, avoid hemodynamic instability, and enable intraoperative neuromonitoring, and ensure early detection and management of complication. And anyone you are comfortable with anesthetic technique is good, as long as you are comfortable with it yourself. Normothermia should be maintained throughout. Careful observation, blood loss, volume status of patient should be ensured at all times. And this is because this is a very long surgery, usually hours. Postoperatively, extubation, it has to be smooth because of the surgeon's brainstem, and usually we'll exchange the tube with laryngeal mask afterwards. Smooth emergency extubation, it's a goal of this. Presence of cranial dysfunction and potential for aspiration pneumonia may sometimes necessitate postoperative ventilation, and this is extremely rare. I would guess that less than, I don't know, 20% we end up with ventilation, but usually we wake them up on table immediately. Postoperative nausea and vomiting, it's quite common in brainstem because he operated in brainstem and there is centers in there, and usually they need some painkillers. Although most of brain surgeries are not painful, this is probably the only one brain surgery is painful because lots of muscle and dissection and manipulation. Probably some opioids to control pain after these surgeries is a good advice. Thank you very much.
But none of our patients leave theatre on a ventilator. We have to wake him up and see whether he's awake or not. As I said, the notion that send the patient to rest is not medical. It's Dr. Majid, you asked me about brain stem, brain death, and I can tell you we can do this next week.
Yes, please. On brainstem death, it's صراحة in this country there is a lot of probably misuse of brainstem death. وأنا I tried بالمجلس الطبي الأردني خاصة for anesthesia residents several times to do this talk, لأنه I was faced during my career some doctors, neurosurgeons to switch ventilators off from patients, even with this clear exclusion criteria for brainstem death. I mean, to do brainstem death, you have to have some set of inclusion and exclusion criteria. Without even doing these criteria, I've been asked to switch off ventilator, which is, I think, needs a very, very good
next week, for all of you, next week we'll discuss brainstem death. And the neurosurgeons who want to switch off the ventilators, we are mediocre as a neurosurgeon who want to kill the patient so that his problem would die.
Where it's why there's a prerequisite of having two
Teams
signatures
and of course.
To confirm the diagnosis. The problem, mediocrity is no short supply. So having two signatures is not a difficult thing to have.
Sure. This is our constant form. I have talked about so many times. It has to be detailed, specifying everything, and I specify that death can happen, or say shalal, paralysis. الدكتور قصدك يعني شوية ضعف شلل قصدك بروح بسرعة لا it may be permanent. They should know this is a major surgery. They should be put in the picture. Sitting position as Dr. Mahavi said. And this is a view of our theater. Microscope and everything, and we use cranial nerves monitoring, we use navigation, and there is navigation people here, Dr. Said Khalid Saleh, are using this machine for navigation. It's very helpful, like in this case. So let's see the surgery. It will take 3-4 minutes, and then we're finished. So it's sitting position. This is right, this is left. We have removed the occipital bone. This is right cerebellum, left cerebellum. This is the arachnoid. This is the cisterna magna. I will just proceed like this quickly. I open the arachnoid. This is the cerebellar tonsils. Now I am at the floor of the fourth ventricle. This is the midline sulcus, which I mentioned. This is here the facial colliculus. And there is some staining, but remember, the lesion is deep. It's not present on the surface. So should I open at the site of the staining? The answer is no, because this may not be the site of the lesion. So this is what I'm showing to the residents in the room. This is midline sulcus, the stria medullaris. This is the staining, but it is not overlying the lesion. The lesion is actually more lateral. So what do? I use the navigation to make sure that I'm in the right spot. Look at the staining there, and the lesion is here. So we don't go by staining, we go by proper anatomy knowledge. I know it is there, so I open a small opening. Again, it is lateral to the facial colliculus. I'm avoiding the facial nerve and this is the lesion. This is the blood of the cavernoma. It's not enough to evacuate the blood. Some people just evacuate the blood. No, we have to remove the lesion.
Was it clotted or was it?
It depends on the stage. If it is early, it's liquid. It's late, it is solid. So we remove the blood. But as I said, this is not enough. We have to go for the lesion. And this is the clot. I'm not after the clot, I'm after the lesion.
You identify that feeding artery?
Yes, we go around it and coagulate it, of course. Otherwise, it will bleed again. It's like an AVM, but you don't see the feeders on angiogram. That's why it's called cryptic. So you are inside the pons, you are operating inside the pons, and your all parameters are going well. So Mavi is telling me, go ahead, there's no problem. Or stop, there is cardiac arrest, so I stop. Or stop, I have air embolism, I have to stop. And then he will put the table backwards so that the head of the patient will go back. There is not a case of sitting position without air embolism, because it happens when you open the skin and the muscles. The idea is to discover it and treat it. So we go into very important points of making sure that there is no bleeding. This is the lesion. Still there is a lesion. Here it is, here it is. So you have to do it under the microscope. And you would wonder how neurosurgeons, still the mediocre one, still doing it without microscope. They say, I will do it with my goggles. The ones who use a microscope, they have poor vision. You have poor vision, we don't have poor vision. The microscope is needed for coloration, for magnification, for everything. So any neurosurgeon who does not use the microscope belongs to the Middle Ages. So trying to remove the last bit of the tumor. Here is a feeder. I want to make sure that it's taken out.
Explain the feeder did not have the hemorrhage as you expect.
Because it's tiny. That's why it doesn't appear on the MRI, on the angiogram. It's tiny little, but you can actually see them. Make sure that we have removed it completely. I will stop only when I see this, the normal color of the brainstem. That's it. So I know I have removed it completely. And then we do hemostasis. This is Surgical inside, hemostatic agent. So here we are. This is the midline sulcus. This is the facial folliculus here. Have not touched the facial or the, and we have done it through a safe entry zone, though it was an intrinsic kind of lesion. This is the pica. This pica. And then you just go out. Okay. As pathology, Dr. Carson.
We do this quickly. I know it's too late. You can see this is a capilloma, and this is typical communicating channels. It's not single channels, communicating channels. And there is fibroblastic proliferation in the wall. This is very abnormal wall. Again, you can see they are communicating channels of abnormal walls. And many cavernomas, they have hyperchromatic lining of endothelial cells. If you are not experienced, you may call this angiosarcoma or something, but you have to be accommodated to call these things. And many cavernomas, they have thrombi in them. And this is very important. And I wonder in the clinical course, when the thrombi form in capilloma, does this change the clinical course or the patient will present or not? I don't know. But you find clotting in many of them. And you can see how these are arborizing or communicating channels. And some of them are very near the surface that you're afraid that some of them will rupture. Again, the other things that I wonder whether there's some bleeding inside the bleeding. So you see hemosiderin macrophages, because this indicates that there is bleeding extra to the communicating blood vessels. And this again, you can see how the wall are thin and filled with the blood. This I just want to show you this cautery mark sometimes. If this is the only thing that we have in pathology, sometimes we have difficulty. But Dr. Ibrahim knows that we have to submit tissue without cautery mark, and this is brain tissue adjacent to the capilloma. Again, you can see how the cells sometimes can be hyperchromatic hobnail appearance, typical of cavernomas. This is a stain CD31 and endothelial stain. You can see how they mark them very well. يعني كأنه رسام رسمهم staining stain the endothelial cells. This is CD34, another stain for endothelial cells and stains other things. طبعا we use them for different purposes. This is actin. It shows you how the blood vessels are very thin. They don't have the smooth muscle typical that we see in large blood vessels. And this is GFAB, that you can see that the capilloma is inside or near the brain tissue or glia tissue. Key 6-7 usually is as expected, is usually less than 1%. So this is a benign lesion capilloma.
Thank you. Postoperative MRI, the very next day, not after a few months, next morning. You can see where we were. No complications. Why do we do this? For the benefit of the patient, for the benefit of ourselves, for confidence, for trust in the residents. They should know what we are doing. Not to hide. We don't need, and you know always that at the end of surgery, Dr. Maria knows, we wheel the patient out and we meet the family, speak to the patient, make sure that the patient is doing well, and we'll give them the tape of surgery. It's a sign of confidence. We're not hiding anything. Again, postoperative MRI. And this is the discharge summary. The length is the discharge summary that we always mention. And this is a photo he sent to me from Iraq. He's back to work in his father's station, that is the printer station, and he's doing well. With this, we finish, and if there is any question, please ask. Any questions?
Yeah, comment on the radiology. I think diffusion method is very important, but also Dr. Ahmed, he knows better that susceptibility weighted images, they are much more important because it's more sensitivity of hemoglobin, and you can detect multiple. Mind you, carcinomas, they can be multiple in at least 25% of cases,
especially after radiation.
That's excluding familial carcinomas. So it's very important to have this kind of imaging. It's even more important than the diffusion weighted imaging, the susceptibility weighted imaging. This is very important.
Yes.
It's not much more sensitive for multiple, so to keep in your mind that they can be multiple often. And the other important thing is really the assurance of complete resection of that one, because they can recur, and they recur highly if we leave part of it. So
they leave
part.
This is very important. The difference between recurrence and no surgery that has been done.
Can you elaborate on that?
I think I'm not can elaborate more. It's a sort of diffusion weighted imaging with motor accessory stimulation, and having the tracks the difference in diffusion during the sensory or motor activation, and then you can image that. I think Ahmed can elaborate.
You see difference in diffusion, one side, one direction, in 3 dimensions. In 3 dimensions you can see it. فبالتالي بنشوف التراك اذا كان انتيرو ولا ابر لور ولا فكل واحده لها كلر معين وبالتالي انت تعرف التراك.
I think they need simulation. To do this. They need tensor imaging.
This is software. ما في stimulation. هذيك تحكي عن stimulation اللي هي functional MRI. Functional MRI we have it in King Hussein Medical Center. It's different completely. But هي تعتمد على diffusion. It's almost diffusion but in 3 dimensions. It's not in 1 dimension.
So for the benefit of the audience, functional MRI you do, and then you ask the patient to do this, and then you will see activity in the motor strip. Or to show him a photo and you see activity in the occipital lobe. This is different from tractography, which you need for surgery. Dr. Jabir, I want to ask you, do you see such lesions in the pediatric practice? Because it's common in...
Of course, we see that, and I'm very happy that I made it today to be able to learn a lot from you. We see that, and we should refer it to the right person once we see that. But I noticed that you really had the reference about children's journal about the complications of surgery. Yes, we do see. Thank you.
Thank you.
I have to say that sometimes gliomas and pediatrics are very different than those from
others.
This is in general regarding brainstem lesions. Have you ever operated on a brainstem lesion that patient presented with locked-in?
Well, yes, I did.
And it was a glioma?
It was a bleeding area. Mainly locked-in syndromes. I've seen it in ruptured pontine or brainstem AVMs.
And he woke up?
Usually they don't. You just want to halt the disease, but usually they don't respond. Once they go into locked-in, I have not seen patients coming out.
Thanks.
Have you? Have you seen patients coming out from locked-in?
No, from a stroke.
Yes,
rather than
sure.
But I was interested in the lesions.
No, sure.
You see lymphomas presenting with some lesions.
Yes, we have seen together. Do you remember the case in 4 or 5 months ago, the Iraqi girl with multiple brainstem?
The reason why I'm having this, it's another depression that would be completely, or the one left, completely masked by steroids, and then these patients, some of them would have been denied therapy that would have affected them.
Thank you all, and next week Dr. Mawi and I will be presenting brainstem death, which is a very important critical issue. So be there. Thank you very much.